Hello and welcome to Season 2 of the EMS on AIR Podcast. The mission of this podcast is to keep healthcare providers safe, informed, and prepared. Today is October 9, 2020. I'm Jeff Lassers and I'll be your host. As promised, we'll be shifting our focus away from the COVID-19 pandemic and moving into other topics of interest for EMS and other related healthcare communities. In this Season 2 opener, we sit down with our good friend Dr. Steve McGraw, who works as an ED physician at Ascension Providence Hospitals in both Southfield and Novi, Michigan. Dr. McGraw is also the current Oakland County Medical Control Authority EMS Medical Director. The OCMCA provides oversight to 54 EMS agencies within Oakland County, Michigan. Even though we're located in Southeast Michigan, and we mention our home state a lot, most of the EMS on air content applies to EMS on the national and sometimes even the global scale. In today's episode, Dr. McGraw kicks us off with a very brief update about COVID for EMS providers. Then, Doc gives us a clear picture of what is at stake for stroke patients. Stroke is a big deal. It's the third leading cause of death in the United States. According to the CDC, in 2018, 1 in every 6 deaths from cardiovascular disease was due to stroke. Someone in the United States has a stroke every 40 seconds, and every 4 minutes, someone dies of stroke. Like I said, it's a big deal, and EMS can do something to help. Dr. McGraw will provide an overview of the evolution of treatments available to stroke patients over the last 40 years. Over this time, the odds of these patients have improved with the advancement of technologies available at our stroke centers. However, to truly realize the benefit, the entire healthcare system needs to evolve its awareness and ability to not only detect stroke, but to identify how severe a stroke is when it's happening. Dr. McGraw and I discussed the evolution of stroke identification by EMS in the field over the last 40-ish years and how it has advanced to the point where many EMS systems across the nation are using stroke severity scales to efficiently and effectively measure stroke severity, obtain targeted pieces of information about the patient, all in an effort to get the patient to the best possible treatment in the quickest and safest manner. We'll also touch on the OCMCA Stroke Systems of Care Special Study, which is assessing EMS's ability to identify and measure stroke in the field using the FAST-ED Stroke Severity Scale. If you'd like more information about the OCMCA's stroke study, or if your agency or hospital would like to participate, visit ocmca.org/stroke. There you'll find all the information you need about the study and how your EMS agency or hospital can participate. You'll even find study data, as well as a few presentations that you can download. And if you or your EMS agency need to catch up on your own stroke knowledge, go on over to americancme.com. There, you'll find multiple courses approved for EMS CEs that focus on stroke. I highly recommend the course Identifying Large Vessel Occlusion Strokes with FAST-ED. This course walks you through the FAST-ED Stroke Severity Scale step by step, shows you how to score the criteria, and provides additional details to successfully guide EMS through the process. Or, if you want to focus on the fundamentals, check out the course Anatomy and Pathophysiology of Stroke, which breaks down the brain chunk by chunk. Or, check out the Large Vessel Occlusion or LVO Stroke course, which introduces EMS to LVO stroke and provides great detail and information. All of these courses are approved for 0.5 EMS continuing education credits in the medical category. Did I mention you could access all of American CME's content for free? Yeah, free. Please keep emailing your questions, comments, feedback, and episode ideas to EMS On Air by email at qi@ocmca.org. Visit emsonair.com for the latest information, podcast episodes, and other details. Follow us on Instagram at EMS On Air and wherever you get your podcasts. And please, whatever podcast platform you use, leave us a rating and a review. It really does help us to grow the podcast. Enjoy the episode. Good morning, Dr. McGraw. How are you today?
I'm great. Good morning, Jeff. Thank you for having me.
Thank you for coming back. Can you please kick us off by providing an overview of the applicable trends as of October 9, 2020?
Well, thank you. I'll channel my best to Dr. Russ Faust. In the United States, we have confirmed 7.9 roughly million cases with just over 213,000 deaths. In the state of Michigan, we have 146,000 cases and 7,193 confirmed fatalities. In Oakland County, we have 17,260 cases with 1,145 deaths, and more importantly, 14,297 folks recovered after confirmed infection. I think the truth is we're kind of hovering along. Our cases in Michigan have not been really falling down as low as some of the other communities that first started this, but we haven't spiked as high as places like Wisconsin are right now. My concern is with the change at the Supreme Court level that our executive orders were nullified. We're now reliant upon public health rules and parameters of behavior. And what I really hope is that people recognize that the disease is still there. And more importantly, that we can control it by wearing masks, social distancing, and making sure we do everything we can to stay home if we're sick, seek testing, notify those we've exposed ourselves to. Since there isn't a robust national trend for test and trace, we're sort of doing it as best we can in Oakland County. But it is still a reportable disease. However, even reporting isn't enough. It's really incumbent on anyone who becomes infected and gets that confirmed to certainly notify anyone that was exposed to them. They need to stay home, follow the advice of their doctors, and only return to normal activities when they have completed their quarantine period and have followed the CDC guidelines on when to return to work. We are, I think, facing a winter that's full of risk, but also full of opportunity where we can perform very well as a society and really keep this largely controlled. And that would go a long way towards preserving life, preserving health, preserving our ability to get our economy back on track. And then fingers crossed on both hands, say a little prayer that we'll have an effective and safe vaccine that we can widely distribute late next spring and summer. That's our goal. That's our hope.
Yes, and as we continue on through the process of this pandemic, this podcast will certainly provide more updates. We'll be talking more about vaccines as they make themselves more clear. But as we said in the introduction, we're actually going to be shifting away from COVID, not completely, because we still need to give the updates like we said, but we are going to shift towards other topics. And one of the main topics for season 2 is going to be stroke. And Dr. McGraw, can you please help our EMS providers appreciate what is at stake for our stroke patients?
It's really been an evolution over my 25-year career to see what we offer to stroke patients and what we expect from our EMS providers to help us do so. To take you a little bit of a trip down amnesia lane, when I graduated from my training program in the mid-90s, stroke really, it was one of those things that you sort of diagnosed, gave people aspirin, and then kind of hope for the best. I mean, we really didn't have a lot to offer. There were some studies done with heparin. There were studies done with aspirin, with medications to lower your cholesterol. But really, there was no sort of meaningful improvement in the care over the previous decade. And then people started recognizing that there was an opportunity in animal studies and human studies to intervene in the early onset of ischemic stroke with medications that dissolve vascular obstruction. And the one that we all now think of, TPA, is the one that has been settled on to be the most effective and the safest. That really was a sea change in how we manage stroke. It went from diagnosing a stroke and wishing people well, protecting their airway, to diagnosing a stroke and immediately going into overdrive to determine if they were a good candidate for TPA, and then if they were, administering it as soon as possible. I remember when the best practice was 90 minutes, and then it was 60 minutes. Now we try to get TPA, the initiation of infusion, at 45 minutes from arrival to the hospital. So you can imagine what that's done. It's sort of pushed out time zero into the pre-hospital arrival, meaning that we really depend on our colleagues who take care of the patient before they get to our hospital to notify us when the patient was last known well, to notify us what the current condition of the patient is from vital signs, give us a little bit of a heads up so we can get our CT scanner cleared, because it's a big ask to assess a patient, score them, rule out contraindications to this medication, get them scanned, get the scan to read, and after the CT is read, begin administering TPA in a timely fashion. It's Herculean. And the more assistance we get from our pre-hospital colleagues, frankly, the better chance we have at pulling that off. Not only do we administer TPA, but then we almost immediately perform CT angiography to see what kind of obstruction is occurring where. And then based on their response to the TPA we give them, determine if is there a hemorrhage present, so we don't give them TPA, or if there isn't a hemorrhage present and we give them TPA, are the arteries likely to open? And what is their score doing? Is it changing over time with the TPA or not? Are they getting better or getting worse or staying the same? Because all those factors in conjunction with our endovascular neurosurgeons will determine if the patient, while having already received TPA, is not improving enough and is a good candidate for intervention, or they receive TPA, there's not enough improvement, but because of some other, usually the location of the stroke, they're not really a candidate for intervention. But all that has to get worked out over the next 45 minutes after we initiate the TPA. So we have 45 minutes when they arrive to give it, 45 minutes to reassess and re-image and do the CT angiogram, interact with our endovascular neurosurgeons to determine what comes next. If what comes next is that they need an intervention, and some of our comprehensive stroke centers or thrombectomy-capable stroke centers, they'll immediately get that. If not, they need to be transferred to a center that can. And a lot of those transfer arrangements have already been made pre-arrival of the patient. We already have these sort of standing agreements. But that said, it's incumbent to make sure that the first 45 minutes is all it takes to get the infusion started. The next 45 minutes is all it takes to get the patient's imaging, angiogram, rescoring done, and the conversation with endovascular and neurosurgery specialists to determine if we can benefit them by getting them to a table. The idea is they'll be out of the emergency department in a grand total of 90 minutes or less. So if it takes 45 minutes to do the front end, assessment, imaging, initiation of TPA when it's appropriate, followed by another 45 minutes to evaluate the outcome of that TPA administration, re-image the angiogram, and talk with endovascular neurosurgery specialists, that's a tight 90 minutes. And it really takes sort of all hands on deck. So much of that is achievable if our pre-hospital providers tell us when the patient was last known normal, what kind of condition the patient's in, because that gets us ready for them, not unlike we do when we have a trauma patient arrive, or when we're given the advance notice of an ST elevation MI. Both of those particular cases, we know from experience, decades of experience, that the pre-hospital care really makes an impact. Really has an impact on our ability to do what we can for the patient faster, more effectively, more deliberately. And I will tell you that in the cases we have that get in and out in 90 minutes, you look back and very often it's because EMS providers gave the hospital enough warning to really be proactively arranging for the CT scan, arranging for the assessment, infusion, CT angiogram, and discussion after assessment with the endovascular neuro colleagues. We're really impacted by what our EMS providers give to us on the front end to what comes out the back end.
So what you're describing is basically best practices in 2020 when all these machine parts are working in concert, and that 90 minutes, man, that's a lot of people all pulling in the same direction to achieve one of the most miraculous things for the most miraculous organ that we're aware of.
Absolutely. We are really, I think, entering a new phase in care of the stroke patient that is highly technical and highly integrated with EMS providers, with our intensive care unit and endovascular neurosurgery colleagues. All the while, nursing staff have to monitor and remonitor the patients. The physicians have to assess and reassess the patient. It is a true team effort from the first call to the PSAP to the arrival in the endovascular lab. It's got to all be everyone working and fulfilling each other's expectations, working together for the betterment of the patient. And I will say it's a revolution in how we handle stroke. As I pointed out, I'm a senior physician, but I'm not entirely a fossil. It's only been about 24, 25 years that I've been doing this. And what really strikes me is how different it is now than when I trained. It's not unlike how different things used to be even before I was a physician with the treatment of ST elevation MI. I remember a time when I was a medical student in 1988, 1989, where truly if someone had an ST elevation MI, they were often given aspirin, heparin, and people just kind of hoped for the best. There were some centers that were taking people to the cath lab, but the real capability and technology wasn't exactly perfect yet. And ironically, it helped some people, but it was hard to predict on the front end who it was going to help. It sounds eerily similar to what we do now, with the emerging technologies of intervention for neuroendovascular emergencies. But what I find interesting is I can see over the horizon that one day an ST elevation MI used to be treated differently than it is now. I think the day is coming when many strokes are intervened upon with or without TPA, if they're not a candidate for TPA, but ultimately many more are going to intervention because the technology and capability will only get better. And that is really, truly what's going to make the outcome of some of these patients so much better in the next decade or two to come than it was 2 decades ago. We're really on the sort of the front end cusp of a revolution in stroke management. I'm really proud that our EMS providers play such a critical role in how that's going to look and how successful it can be.
So let's do a quick flyover to catch everybody up about the last 40 years of the evolution of treatments available to stroke patients at the multitude of hospitals. As a quick little background, primary stroke centers were the first designation of stroke centers, and that wasn't until 2003. Since then, we have essentially 4 different levels of stroke centers. We have acute stroke-ready hospitals, primary stroke centers, thrombectomy-capable stroke centers, and comprehensive stroke centers. And all of those different levels are based on the types of patients that they have and all of the capabilities that they have and how often they have them. Dr. McGraw, can you give us a little bit of a flyover of the evolution of these treatments that have been available at these various centers for the last 40 years, starting with no TPA to the TPA in the 90s, to the treatment of hemorrhagic stroke and aneurysms, all the way through to now with mechanical thrombectomy being the standard of care for a large vessel occlusion stroke?
That's really a great thing to go over. I think it serves us well to remember within my lifetime, we had a point where you didn't give TPA because it wasn't even invented yet. We protected people with baby aspirin and lowered their cholesterol with cholesterol-lowering drugs. And we propped them up to prevent choking, and we fed them intravenously or through gastric feeding if necessary. But it was a time at which we really didn't have much to offer people. Fast forward to the early and mid-90s when it had been demonstrated that in the acute phase of an acute ischemic stroke, TPA, while infused over 60-minute infusion, actually could reverse some of the impact. But we really didn't have much to offer after that. If it didn't work, there were some centers that were looking into performing endovascular treatments and were exploring what the equipment would need to be. But some of the equipment and techniques haven't even been invented yet. We knew in those cases, however, that these patients that didn't improve with TPA, who were otherwise good candidates for it, and we also knew that some of those had really severe proximal occlusions, what we all consider now to be LVOs, large vessel occlusions. But not in very many cases overall were we really able to offer them the kind of technology that, fast forward to the 2000s, we offer in many centers, both comprehensive stroke centers as well as thrombectomy-capable centers. What I'm fascinated by is now we're trying to predict who among all stroke patients benefits from which type of treatment, up to and including intervention. Because not everybody who fails to reverse from TPA will automatically improve with intervention. And I'll say one other thing. The notion of opening with thrombectomy, a removal of a clot, opening an artery, is just revolutionary. But so is how we treat intracranial hemorrhage now, specifically in terms of leaking cerebral aneurysms. At one point, required a craniotomy, meaning half the skull is removed. The angiogram is viewed to determine where a leaking blood vessel is likely to be found. The neurosurgeon, using a microscope, kind of winds his way along or her way along through the blood vessels to find the one that has the sort of the plump cherry of an aneurysm. And then they put essentially a clip or a staple across it. At the time they do that, they're hoping that they don't experience a massive hemorrhage, which could very, in many cases, devastate or even kill the patient. 90% of operative aneurysms in the 80s were done what we call open. Now, fast forward to 2020, more than 90% of our leaking cerebral aneurysms are managed endovascularly with coils, what is essentially a form of a stent that allows the blood to flow around and by the aneurysm outpouching so that the body's own ability to shrink itself and the aneurysm to sort of collapse in on itself will occur. It's like a new day. It's like a brave new world.
For those of you listening who need a little bit more of a basic visual, literally the aneurysm is this little balloon hanging off one of the blood vessels. It's this weakened area that's just waiting to explode, pop open, and bleed into the vault.
And of those that bleed, a third die virtually instantly.
Right.
So another third used to get operated and had some significant neurologic outcome, life-altering outcome. And then another third, or a little less, actually had surgery and did pretty well, could return to most of their active lifestyle to varying degrees. But wow, now a leaking aneurysm is managed essentially from inside the blood vessel.
They endovascular, literally inside the vessel. They go in the femoral artery. They track this thing into the exact spot of the person's brain that has a very tiny little balloon about to pop. They then fill that balloon with a platinum coil. They're like threading a needle from the femoral artery all the way up into the brain, filling up that balloon until it's full of a platinum coil. And forgive me if I'm wrong, Doc, but basically it's a stable matrix for that vessel to heal around and then not be an aneurysm anymore.
It really is a miracle. I mean, I don't think there's that many things in that. There's some, but there's not that many things in medicine that are miracle in technology, but this is like miraculous technology.
And when you watch the video of it happening, like the graphics, you're like, oh, it's so easy. You just fill this thing up. I'm like, oh yeah, they got to go in through a femoral, they got to stick it in his brain. It's amazing how simple, and I think that expresses how the beauty balance between the science and the fundamental understanding of what's actually happening.
Really true. And hats off to the people that do that. Remember, they're manipulating the catheter in the patient's groin crease at the top of their thigh, yet the catheter tip winds its way up through their aorta, up through their carotid, into the vessels of their brain. So they're moving it down at the leg, but the camera and their ability to see where it is being observed while inside the person's vasculature of their brain, inside their skull. Pretty incredible. We take it for granted because they do it every day, but it's just a really remarkable application of science and technology, skill, training.
So speaking of which, so that speaks to the amazement of what we've been doing for hemorrhagic patients. But even after that, and we talked about this on mechanical thrombectomy already, the physical removal of the clot is a little bit newer in the sense of the number of patients it's treated over the last, let's say, 10 years, its implementation. But really, it has sparked discussions throughout the EMS communities about not necessarily identifying stroke patients, but identifying stroke patients and then measuring how severe their disability currently is, hoping that if EMS can identify and then measure the severity of a stroke, we can then add value to the information we express to the hospital so that when we deliver them, not only can we decrease that door to 90-minute time for your TPA, let's get it below an hour. Let's get it below 45 minutes. Let's get people the option of intervention when it's applicable to their situation even faster. So in the EMS community, starting in the 90s, they came up with the Cincinnati Prehospital Stroke Scale. TPA came out and they're like, hey, we need to give EMS a tool that'll help them to identify patients that might be candidates for TPA and then get them to these hospitals right away. That was the first step. Now, I know a lot of people still working in the industry of EMS that had their license before Cincinnati Prehospital Stroke Scale was a thing. I can't imagine that. I didn't get my medical license till like 02-ish, 03-ish. I don't even remember now. But since then, we now have things called stroke severity scales. The Cincinnati Prehospital Stroke Screen is a stroke screening tool. It identifies the presence of neurological deficits or potential neurological deficits, whereas the stroke severity scale is designed to quantify the severity. Originally, these were designed to really identify large vessel occlusion, but doc, you tell me, hemorrhagic strokes, pretty bad. So a severe LVO and a severe hemorrhage are both going to have a high score. So really, this isn't about LVO to me, right?
Well, it's not exclusively, but it does tell you there is likely to be some very massive interruption in blood flow to some part of the brain. When your stroke severity is high, whether it be a large vessel occlusion with a clot or a hemorrhage in a M1 vessel, the physical findings are very similar in many cases. Now, it may even be worse in a hemorrhage because they may have enough brain edema and pressure on the brainstem, they lose consciousness. But you're so right, Jeff. Cincinnati Stroke Scale was really an opportunity for pre-hospital personnel to determine that a large neurologic impact was being felt by the patient, that a stroke of one fashion or another was likely, hemorrhage, aneurysm, or ischemic stroke. Stroke severity is really trying to subdivide those having strokes from those that have either a mild or lower level number of parts of their body affected and systems of the brain affected, and to divide that from those that are having a rather severe impact on the blood flow to the brain and a severe manifestation of that lack of blood flow into multiple systems and capabilities that otherwise would be present. And so it's more nuanced. One is like saying the room has a light on or off. There's either a likely stroke or not. Stroke severity is a dimmer switch. Is it very bright? Is it not only a stroke, but a very severe one? Or is it still likely to be a stroke, but one that's less severe? And our challenge as EMS providers is to learn how to apply that stroke severity to the best potential outcome of our patients. And it will help the hospital, I think, when they know that someone with a very high stroke score is coming in, to recognize that faster, expedite the care, providing them, if indicated, the TPA and the angiogram, and then determining if they need to be taken to the biplane or the interventional lab. How does that happen fastest, and where can they go to get that done in the most timely way? So that's why it's going to be, as we move into sort of EMS stroke management 2.0, we're going to graduate from doing a Cincinnati stroke scale on everybody to doing a stroke severity scale on almost everybody that we think has a stroke. And it's not to say there's no role for the Cincinnati stroke scale. I would argue that it's still a great thing to do.
Yeah, absolutely.
Right? It's just that now we have a way of, in a linear fashion, quantifying, yeah, you have a positive stroke scale, but how severe is it? And now you can relay that to the hospital as well.
Exactly. Now, that's how a lot of them work. These are originally the intent of a stroke severity scale was to identify LVO. But like we're saying, it's really a better way to describe is that it's measuring how bad a stroke might be. How most of them work is, well, first of all, there's two different types. So you'll have a scoring based that produces an actual score. And then there's others that are criteria based. If you have all of these things, then it does qualify as an LVO or a severe stroke. But how they all work is you use a stroke screening tool first, like Cincinnati, and if the patient is positive for anything in the stroke screening, you continue with the stroke severity scale, right? So you go arm weakness, facial droop, the normal stuff you do. But then, when positive, you then move into your stroke severity scale. Now, here's the deal. There are a ton of stroke severity scales right now. The most common is like RACE, also known as RACE Plus. They've made some additions to it. There's VAN, which is making a big movement right now. There's CPSSS, that's the Cincinnati Prehospital Stroke Severity Scale. And then there's the one called FAST-ED, the Field Assessment Triage for Emergency Destination. It is also the steps of the scale: face, arm, speech, time, eye deviation, and denial and neglect. Now, FAST-ED is currently being implemented into the Oakland County EMS Stroke Systems of Care Special Study, where EMS providers are being trained to use FAST-ED as their stroke severity scale. So if they encounter somebody and they think they're having a stroke or they're even having any complaint that's a neurological deficit, they do a Cincinnati. If positive, they continue with FAST-ED. Now, throughout this season, we're going to get deep into what we've been doing in this study. But Dr. McGraw, we've been doing this study for about 2 years. Can you give me a little bit of a flyover of what you thought about the study initially and what you've learned in the process? And we'll go over the data in another episode. But give me your anecdotal feelings so far about this study.
Well, I learned, I think, 3 really important things. The first of which is we have exceptionally great pre-hospital providers in our county, in our system, who are new adopters, who have embraced the notion that they can help subdivide people having strokes. So I learned a lot about them. I also learned that they're capable of being trained and learning from that training in a way that demonstrates reproducibility of the actual score. Just like my partners and I had to learn to use an stroke scale in the emergency department, and we had sort of a learning curve to climb with that intervention, so too our pre-hospital providers have had a learning curve in how to both score and use FAST-ED as a stroke severity scale. But having said that, the learnings I've seen over the last 2 years give me enormous confidence that we'll only continue to improve and get better. And I would argue that it's very similar to what we had to learn when we were all trying to learn to read EKGs in the field. We're better now than we used to be. And I think the FAST-ED stroke severity scale will prove to be in a very similar way, improvement over time. The third thing I think we learned, and maybe this to me is the most meaningful, is that when we know a stroke severity on a patient and anticipate it in the emergency department because it was given to us by the pre-hospital providers, it changes how we approach the patient. I would argue help us triage and more rapidly assess, image, risk stratify, infuse our TPA, and reassess with imaging of the cerebral angiography in a way that is much more rapid than if we didn't have a stroke severity scale that was a big number. We've seen how that correlates with the NIH stroke scale, and not coincidentally, when the stroke severity scale by FAST-ED is high and the NIH stroke scale is high, which they usually are, they correlate, we are much more capable when we know earlier that the patient's coming of infusing the TPA and imaging and getting the results of the imaging back in a timely fashion. Ultimately, since time is brain, time is neurons, that's going to lead to better stroke outcomes for our patients. And that's the part I think of having been on this journey now for several years that I really see as the future. I think that's what's coming our way. So I want to thank those in our partners in the pre-hospital world that have done this and taken it upon themselves to learn how to do this and do it to best effect for our patients. You make us take care of the patient better by taking care of the patient better yourselves. And ultimately, that's what teamwork is. And when we give it more rapidly and get them to if necessary, the biplane more rapidly, the only thing I can say is if that's me or someone I care about, that's what I want. That's the kind of state-of-the-art, integrated pre-hospital, ER, and neuroendovascular care that I think everyone having a stroke deserves. And I would sure want that for those that I know and love, and I'm certain I'm saying the same thing that we all feel about those that we care about in our family and friends.
That's all for the show today, everyone. Thank you, Dr. McGraw, for taking the time to record with me today. As always, you provide great insight for our EMS providers to consider the next time they encounter a possible stroke patient. Please keep emailing your questions, comments, feedback, and episode ideas to the EMS On Air podcast team by email at qi@ocmca.org. Visit emsonair.com for the latest information, podcast episodes, and other details. Follow us on Instagram at EMSOnAir and wherever you get your podcasts. And please, whatever podcast platform you use, leave us a rating and a review. It really helps us to grow this podcast. Thank you for listening to the EMS On Air podcast. Stay safe and have a great day.